Thank you, CY, for the kind introduction. It's a pleasure to be back in China, and this time in the city of Chengdu. So I'm super excited to be sharing my passion in obesity management with you all today. So without further delay, let us get started. Before I dive into the details, let us do an activity. Please do raise your hand if you agree that obesity is a disease. 肥胖是一个疾病. Do you agree with this statement? Wow, fantastic response. It seems that majority of you do agree to the statement, and so do I. Based on medical dictionary, a disease is defined as a deviation from normal physiology of an organ or bodily system that have a negative health outcomes to a person. At the same time, it also causes specific signs and symptoms. So does obesity fulfill all the three criteria? I'm here to convince you if you are not already been convinced. Let us look at the global picture. Currently, we have 2.5 billion adults living with excess body weight, meaning that they are either in the overweight category or obesity. And among that, 890 million of them actually are in the obesity category of various classes. And that prevalence has already doubled since the 1990s. Over the next 5 years, the trend is worrying us a lot. By 2030, it is estimated that 1.1 billion people are struggling with obesity. At that point of time, about half of the world population will have excess body weight. Therefore, I'm not really surprised that in certain journals, we call obesity as the global pandemic, though usually the word pandemic is used for communicable diseases rather than non-communicable diseases. These increasing numbers are not just any statistics. They translate into large burden of diseases. When adipose tissue becomes too much in our body, it also becomes dysfunctional and causes systemic inflammation. This is what we call as adiposopathy or sick fat disease. And this is the process that underlies many of the cardiometabolic obesity-related complications we see in our clinic day in and day out, such as diabetes, hypertension, fatty liver disease, and cardiovascular diseases. At the same time, that huge amount of fat deposition in our body also creates mechanical stresses in our body, which I refer them to fat mass disease. This is the causes of how obstructive sleep apnea, osteoarthritis, and reduced mobility happens in our patients struggling with excess body weight. Apart from the cardiometabolic and mechanical issues, obesity also impacts on someone's mental health, from depression and anxiety to psychological burden of weight. All these categories of complication, be it the mechanical, medical, or mental, they can present in various degrees, as we know from our clinical practice, and it put on a huge burden on our healthcare system, financially, socially, economically. In such an important medical condition like obesity, prevention is very important at all levels. So we have 4 levels of prevention here. The primordial prevention is whereby we try to prevent risk factors from emerging at the population level through effective policy implementation. For instance, one of it is the sugar tax policy. Second level is the primary prevention, where we prevent obesity from happening by educating children and families the importance of balanced nutrition and regular physical activity. For the tertiary and secondary prevention, here are those prevention level for patient already struggling with excess body weight. In the secondary prevention, we try to prevent someone from further weight gain and help them to initiate some form of weight loss. For tertiary prevention, we are trying to treat the obesity-related complications to prevent further long-term harm. Secondary and tertiary prevention are really where healthcare professionals like us work at and has the biggest role. But before we talk about how to treat obesity, the fundamentals are important. I'm here to discuss on how to tell you and guide you on how the body weight regulates itself and how obesity develops. And of course, after knowing this, today we have a well-planned event that you will learn the strategies on treating this disease. Traditionally, weight was explained by a very simple mathematical equations, calories in versus calories out. But this model cannot explain a lot of things that we see in our clinical practice. I'm just going to name a couple of them. First one is that when two persons eating the same meals, why do they gain weight differently over time? Another example is that for certain patients, they already lose some weight, why it becoming harder and harder for them to lose weight over time? So what actually happened? Clearly, if we were to follow these simplistic mathematical models, there will be gradual incremental or reduction of weight over time, but it just doesn't happen. So something is clearly missing with this formula. Today, we know better with the science, publications, discussion that body weight regulation is a complex process. It is an integrated system of a brain axis, a brain-gut axis that involves hormone from the GI tract, such as liver, pancreas, and small bowel, plus adipose tissues. These hormones then feeds into the brain on how they interpret satiety and hunger. Obesity is caused by dysregulation of this system due to multiple various internal and external factors. So how does the brain regulate our eating behavior? It consists of these main three important systems. The first one is homeostatic eating. We eat because we are hungry, in need of nutrition. Number two, hedonic eating, whereby we eat because of a pleasure and reward sensation. That's why there are sometimes when we feel full, there's no need for nutrition, but we keep on thinking the pleasure and reward in regards to food, and we will be chasing for food. Here's where hedonic eating resides. And finally, the third system is executive function, where our brain decides to eat or not to eat voluntarily. The homeostatic eating center is situated in the hypothalamus, and it integrates all the hormonal signals from the GI tracts that regulates appetite, balancing between satiety and hunger. Mesolimbic reward pathway is the system that controls hedonic eating, and it consists of ventral tegmental area, nucleus accumbens, and lateral hypothalamus. There are two main circuits in this hedonic eating center. Dopamine circuits relates to motivation and driver towards food. Here's where we say, I want, 我要. While the opioid cannabinoid circuit will regulate pleasure associated with meals. Here's where our brain, or we will say, 我喜欢. Overall, this is the site that controls the symptoms such as elevated liking, wanting, and cravings. Now, executive function is located at the prefrontal cortex, or the frontal lobe of our brain. It controls high level of cognitive skills such as planning, focus, and decision making. Here's where lifestyle counseling works on. There are many appetite-regulating hormones in the GI tract and fat cells to regulate energy balance in response to someone, whether they are eating or fasting. So, over your left side, is the only hunger hormone in our body. It's called ghrelin. It's produced by the fundus of the stomach. And we can see here the other three columns show you the satiety or fullness hormone that's secreted by various organs. I'm going to name a couple of them. So we have GLP-1 from small bowel, we have insulin from pancreas, and we have leptin from adipose tissue. So these are all fullness-inducing hormones that are produced by our body based on what passed through our gut. This hormone then acts in the arcuate nucleus of hypothalamus, where the homeostatic eating center is situated. And in that center, there are two major neurons. The hunger neurons, called AGRP, NPY, and the fullness or satiety neurons, POMC, CART. So what happens is that ghrelin, the hunger neuron, will stimulate the hunger hormone, stimulates the hunger neurons, and then inhibits the other satiety neurons. And same for satiety hormones, it will stimulate the satiety neurons, then inhibits the hunger neurons. But the brain doesn't do all this in a random fashion. It doesn't regulate hunger, satiety just whenever it likes. It's actually defending a certain weight set point, which explains why weight loss is so biologically challenging. Each individual, you, me, and other people, different races, different genetic profiles, we have different kind of set point that our brain set. So when weight drop below this set point range, the body will respond by increasing hunger signals and reducing energy expenditure. This is why sometimes we will hear patients say that, I can lose weight with diet and exercise. But at one point, I find maintaining that weight loss, continuing weight loss is so difficult. I feel hungry, or whatever I do, I intensify, it just doesn't work. It's not that our patients are not trying hard. It's just that the body is trying to pull them back to the set point they are supposed to be as our brain perceives to be normal. And in people struggling with obesity, this set point is at a higher range. So the brain perceives a higher weight as the normal and decide to defend towards it. Whenever someone loses weight by increasing their physical activity, reducing food intake, there are counteractive mechanisms happening in our body to defend that set point I mentioned. The hunger hormone increase, the satiety neurons will reduce, and at the same time, metabolism will then slow down. This is what we call as metabolic adaptations. So by itself, it's a defense mechanism to ensure our human race survivability, because 1,000 years ago, losing weight just means bad news. It's not like we are trying to lose weight to look nice in our dress or suit to attend party or wedding. So to ensure our survivability, this is in our body. But it is also one of the causes why patients have difficulty to maintain weight loss in a long-term fashion when they are using lifestyle intervention alone. And there's another common scenario in our clinical practice. So you can see here, Mr. A over your left side, if he eats the food in the picture shown here, he said that, well, I don't gain any weight. But Mr. B over the right side, if he eat the similar food, he said that I will gain 3 kilograms over 1 to 2 weeks. So what actually happened? Is it that because I didn't get the full history from the patient about their eating behavior, physical activity, or they may have underlying pathology or diseases such as diabetes, or they are on certain medication? But at the end of the day, most of the answer lies with the patient's genetics profile. This paper shows you that individuals who are genetically predisposed to obesity, they are so much easier to gain weight when the environment becomes increasingly obesogenic. As compared to the light blue chart down there, these are the individuals less susceptible to obesity based on their genetic profile. and their weight remain quite stable irrespective of the environment becoming more easier to gain more weight. And that interaction between genes and environment, when we clash together, is even more prominent when we look at the twin studies. Monozygotic twins, as we know, have the similar genetic profile between the two twins. As compared to dizygotic twin, they tend to have a similar body shape and sizes even when they are raised apart. So this tells us that genetics can strongly limit how much the environment have an influences on our body weight. It's estimated that obesity heritability is up to 20%. So imagine a patient present to us struggling with obesity. There's a 70% chance that his immediate family members will have obesity, or up to 70% of his relatives are also struggling with excess body weight. So the importance of genetic is emphasized here. So up until the slide just now, we have discussed the internal factors, the genetics that predetermine someone's weight set point and about metabolic adaptation. How about the external factors? And when we talk about external factors, we couldn't run away from stress and lack of sleep. You know, we are now living in a modern society, and be it due to work, commitment, family, or medical issues, this stress and lack of sleep will most likely happening to 80 to 90% of us. And that will cause prolonged secretions of the cortisol, and then it will activate the hypothalamic pituitary adrenal axis that change the energy homeostasis in our body in promoting more weight gain. Because when we feel stress, we will have the cravings for higher fat, higher sugar, higher salt content food, because that kind of food will make us happy, the hedonic eating part. We are feeling stressed, so in order to overcome, we want to release the stress. And there are many causes of this vicious cycle of stress and weight gain, be it mental disorders, patient underlying medical diseases like sleep apnea, diabetes, or certain medication use also causes stress to our body. Lack of sleep also have quite a similar pathway on how it has a continuously increased cortisol secretion, and then stress, weight gain, vicious cycles, on and on. Other than stress and lack of sleep, our other obesogenic environment also increases the risk of someone to gain weight in our population. So we are now eating more because food are so easy to access. Nowadays, you click on your handphone and you can get the food delivered right to your doorstep. I mean, the even more drastic example, up to your bed. And at the same time, our food now are designed to stimulate us to buy more and eat more. So we have scientists who are helping this manufacturer to trigger our taste bud and wants us to eat more for hedonic eating. At the same time, is our environment well structured and well planned to encourage us for physical activity, go for exercise or leisure activity with our friends to encourage movement? Well, unlikely, because there's planning and cost involved in structuring this. So this obesogenic environment then clashes with the genetics for individuals that more towards obesity. Then that's why we can see such a increased prevalence of the disease. So when we combine the internal and external factor I have discussed up to now, I must admit that obesity is not only a disease, but a complex multifactorial one. And with such complexity of a disease, it requires a multimodal approach. And I divided the treatment pillars into three: lifestyle intervention, obesity management, medication, OMM, and metabolic bariatric surgery. And in our practice, it's becoming common to see these three in combination rather than on their own alone. Before I end, I have three take-home messages I hope you get is that, number one, obesity is a disease. Number two, it arises from energy dysregulation, which is regulated in the brain by neurohormonal signals, genetic and its interaction with our environment, obesogenic environment, drives someone's risk towards excess adiposity or excess body fat deposition in our body. And lastly, obesity is a treatable, complex, chronic conditions, and the pillars of treatments is beyond lifestyle intervention alone. With that, ladies and gentlemen, thank you for your kind attention.